few years, but I wanted to just shed some light on things to consider when we think about psychosocial support services, particularly for our young adult colon cancer survivors and how they might be optimized. So I want to add to this slide fighter, because Katie mentioned the word cancer fighters and survivors this morning, and I think that's a terrific word, but this is just to put into context that cancer survivorship has been defined as the time of diagnosis onward, and so everyone is surviving, but I also like the addition of the word fighting, so thanks, Katie, for that. So there are a number of consequences when the psychosocial needs of cancer patients and survivors are not met. In cases of when persons have low social support, we know that diminishes their ability to cope effectively with their disease and thus to effectively manage their illness. And we know from epidemiologic studies that low social support also can have negative effects on health outcomes. Emotional distress can have medical implications in that it can impair cognition and the ability to fully understand and grasp important information. It can impair adherence to treatment and also preventive consequences. It can deplete motivation and also impair coping skills. Chronic stress, if it's not addressed, can result in other health conditions like depression, and also may result in physiological changes as well that could impair health. And then I think this was raised incredibly well in the last panel with regard to the impact not only on patient, the survivor, the fighter, but also their families and the communities that they exist in, and that the impact of cancer on a person really does affect a number of other factors, both that person with regard to their contributions to their families, to their communities, also caregivers and the burden that they receive. So in 2008, the Institute of Medicine, formerly called the Institute of Medicine, which name is now changed to National Academies of Science, Engineering, and Medicine, issued a really landmark report called Cancer Care for the Whole Patient. And they really highlighted some of the gaps and deficiencies in psychosocial care for cancer patients and survivors, and what some needs were in moving forward. And I think for many of us, we believe that this was a major table turner with regard to raising awareness of what needed to be addressed. I want to note that they called the need for psychosocial care as psychosocial health care. So not just psychosocial in terms of a broad range of issues that psychosocial as a term can encompass, but looking at psychosocial health as a critical component of cancer care and cancer outcomes. So they highlighted the need for psychological and social services that would be integrated into cancer care, and that they also highlighted the need to include these services so that patients would be enabled to optimize the medical care that they receive. So they clearly drew the linkage between the medical care and the psychosocial care, and really forced the light to look on those as intertwined. And also they called on the need to manage psychosocial, behavioral, and social aspects of cancer to promote better health in general, because it's not the cancer patient who's just being treated, getting through treatment, but it's also preparing for life beyond cancer and the life that you're going to live afterward as well. So they proposed some standards of care on this table. One is to facilitate better communication between providers and patients so that patients can get better information, have a better dialogue with the needs, and then to identify, to really assess and identify what each patient's individual psychosocial health needs were. That's a critical starting point as well. And then in thinking about coming up with a plan for psychosocial health care, it would involve linking patients with whatever psychosocial services are needed, coordinating these services with their biomedical care so that the consequences of their medical care and the impact on psychosocial outcomes could be integrated and could be addressed simultaneously, and then also in engaging and supporting patients in managing illness as well as promoting their health. And then also then systematically following up on not just one assessment at the beginning of diagnosis, but constantly checking in, frequently checking in to identify what needs remained and what needed to be addressed. So these are an outline of psychosocial needs that they identified. I'll run through it very quickly. First is just a basic understanding of illness treatments and services, as we heard from some of our panelists. The search for information, just trying to understand what's going on. It's very daunting even for the most health literate of us.
and strategies to improve patient-provider communication were seen as instrumental for that. Identifying ways to cope with emotions and distress surrounding illness and treatment could be addressed through peer support groups, through counseling services, psychotherapy, as well as any pharmacologic interventions. And then managing health as well as illness and looking at more comprehensive self-management and self-care programs. Behavior change to minimize disease impact. We know a lot more now about the impact of lifestyle behaviors on both recurrence as well as survival for cancers. And so it's important to consider things like tobacco use, obesity, physical activity. Those can be very impactful on survival and development of later comorbidities. And in fact, the cancer diagnosis could potentially be a teachable moment for reducing some of these health behaviors that are negative. And then managing disruptions in work and school and family life, looking for ways to support that, and then also financial assistance, and not just with insurance and access to care, but I think more light is being shed on what has been called the hidden costs of cancer care, but maybe they're not so hidden, but things like the cost of transportation, the cost of loss of work, of child care, of all these kinds of things that had not perhaps been given much attention to, but really can be very challenging to deal with as survivors and fighters. So how is the care of psychosocial care for cancer survivors improved? One way is by instituting care standards and practice guidelines. Initially, the first step to this is really instituting some initial steps for just screening and identifying distress and emotional well-being in patients. The National Comprehensive Cancer Network, the NCCN, which is a leading guiding authority for cancer care guidelines, in 1997 came up with some initial guidelines for distress screening. And then upon identifying persons who are at elevated distress, referring on for services and then management of that distress long term. What's required to do that is not just a physician's eyeball or provider's eyeball, but really to identify some valid tools that are standard and that can be used to identify distress, that have validated cutoffs that would initialize a referral when needed. And a study that was done that utilized a valid patient-reported distress tool that had a valid cutoff point indicating a need for referral versus simply an oncologist rating of a patient's distress showed that in the patient self-reported group, 69% received referrals versus 6% in the oncologist group. And in the patient self-reported group, 28% accepted those referrals versus 4% in the oncologist group. And that's not to try to diss the oncologist. It's very difficult to rate a person's distress without having them indicated somehow, and I think this points to the importance of self-report. So another way to ensure better provision of psychosocial health services is to measure the quality of this care. And so the American Psychosocial Oncology Society formed a task force several years ago and identified a couple of key criteria by which quality of care, psychosocial care, could initially be addressed. And one is, again, beginning with the topic of assessment. And a simple question of, was the patient's emotional well-being assessed within at least 1 month of the first oncology visit? And then the second was, if a problem was identified, was an action taken to address that problem? And several studies have shown in medical care in general, but also in providing psychosocial health care, that providing feedback on the quality of care can really be helpful in providing improvements. And over a course of 1 year, when looking at changes in assessment after the implementation of care guidelines, one study found that assessment improved from 64% to 73%, and taking action based on assessment increased from 74% to 76%. Not statistically significant, but still an improvement. And in fact, it's been suggested that providing feedback may actually be more feasible in increasing the provision of psychosocial health care in settings rather than devoting many resources to implementing new services. Not that those new services aren't needed, but this is a step that might be simpler and easier to implement that could achieve outcome as opposed to introducing new services, which can be costly and also can encounter a number of barriers. So these points were eloquently echoed by the panel a few minutes ago, but just the understanding the quality of life concerns and the impact of cancer on young cancer survivors The conceptualization of not being sick, but not being healthy, and really understanding how to manage the distress and emotions related to treatment, fear of recurrence. For this group in particular, particularly some of the younger ages, adolescents and young adults, which we deal with a lot, the social aspect is very important, social functioning, isolation, how do you disclose, how do you communicate this information. The reestablishment of normalcy and identifying the new normal, which is what we talked about last year. Issues of intimacy, sexuality, fertility, very critical for persons at this stage in their lives. And then again, coping with the issues of loss, whether it be job, school, appearance change, relationship changes, but also noting that there can be positive attitudes, beliefs, and positive feelings emerging from the growth that one can experience through cancer. So I'm going through that very quickly. Just to close, these are some topics that we're addressing within MD Anderson in the ongoing and evolving development of an adolescent and young adult cancer center within our cancer center. And some of these services will go up to age 29 or 30, some will go up to age 39. We have three aspects of it. One is just a general survivorship care program. So this is providing ongoing survivorship care after completion of treatment. Another critical area is fertility and reproductive medicine, so focusing on those needs, particularly up to ages of in the 30s and even early 40s. And then the psychosocial program, which I'm involved with Dr. Martha Askins, one of our clinical psychologists, that would involve a thorough and comprehensive psychological assessment and counseling and follow-up of any needs are identified. This can include also psychotherapy, neurocognitive testing if needed, career and vocational guidance, and educational consultation for survivors and patients who are entering school, jobs, or re-entering, whatever the case may be. Young adult life services, which would encompass not only our patients and our survivors, but also families, caregivers, spouses, children if needed. We have an arts and medicine program that provides a therapeutic approach through the arts, for coping with cancer and its impact, and then peer support as well through our Cancer 180 group, which was named such because of our young adult cancer survivors who said when you are diagnosed with cancer, it's a 180 turn in your life. In addition to that, I think it's important to note that there are other specialty services that should be called into play. Obviously pain, palliative care, and palliative care is not just at the end of life, but throughout treatment as well to effectively cope with symptoms. Integrative medicine can play an increasingly important role. We have a body image therapy program that provides counseling and support in coping with physical changes following cancer treatment. And then also looking at some lifestyle behaviors. We have an energy balance research program that focuses projects on exercise and diet and weight reduction, and then also tobacco treatment, which provides evidence-based tobacco treatment for tobacco use and cessation. And with that, I'm going to have the pleasure of turning over to Dr. Deborah Wolf, who's joining us today and who's going to speak to us on some really important legal and other aspects of getting one's affairs in order. So thank you.